Okay, hello and welcome to another live broadcast with MedStar Health. My name is Karen Zingle and I'm joined today by Dr. Lucy De La Cruz. Today, we're going to be discussing breast health and breast cancer treatments in honor of Women's Health Week. So if you'd like to know more, including breast cancer treatments, we're going to talk about the types of mastectomies that are available for patients. We're going to talk about nipple-sparing mastectomies, and also when it's important for you to seek consult. We invite you to stick around, share this broadcast with your friends and family, give us a like, let us know that you're watching. And if you have any questions for Dr. De La Cruz, you can ask them in the comments below. So first of all, thank you, Dr. De La Cruz. Welcome. Thank you for joining us today.
Thank you for having me, Karen. It's a pleasure to be here today.
Before we begin, can you tell our viewers a little bit about yourself and the importance of breast health?
So I'm Lucy De La Cruz. I'm a breast surgeon fellowship trained. I was also did a general surgery residency. And I currently see patients at Georgetown and Lafayette. I take care of patients who have benign disease of the breast, as well as patients who have breast cancer. I have a special interest in male breast cancer and their surgical management of their disease, as well as high-risk patients, such as patients who have a strong family history or patients who have a genetic mutation, kind of what most people would call the Angelina Jolie gene, which is medically known as the BRCA mutation, or other mutation carriers who are increased risk of having breast cancer.
Thank you so much. Can you tell us a little bit about your philosophy on how you about the treatment of your patients? What's your philosophy of care?
One of the things that I truly believe is in taking care of the patient, individualized care of the patient, meaning, not putting them, I always say, not being a cookie cutter physician, but really being a person who takes care of in a very specific approach to that specific patient, and making sure that their care is tailored to their needs, which I think in our field is very much of a field that it allows us to do that, because the answer is not always, so straightforward. It takes a lot of thought process. And obviously the collaboration of multidisciplinary approach that we use at Georgetown or at MedStar Georgetown Hospital when it comes to breast cancer treatment, which is essentially a collaboration of a team of experts that deal with breast cancer, in not only in the surgical field, but also in the medical oncology field, the radiology field, the radiation oncology, plastics, and other providers who support that journey or that treatment, such as supporting staff, such as our social worker. We have nurse navigators, physical therapists, and other people who participate actively in their care. And also even for patients who don't have breast cancer, patients who are high risk, also to be thoughtful about, recommendations, when to start screening, what imaging they need for screening, how often they need to see a provider, and kind of putting them in a much more of a one-to-one, approach, rather than, this is where you fit and this is where you should be. And sometimes that doesn't work out for everybody, right? Everybody has different needs, different expectations of their care. So it's truly about analyzing their care to make sure that their outcome is the best.
Absolutely. Yeah, that is great. And it's a team approach. It's a team effort, because everyone's needs are different and unique, and there's lots of step in your journey, regardless of what that is, and you need help every step of the way. So it's great that we have that, and it's great that you're a part of it. What got you in this line of medicine?
I'm fortunate, I say, mostly because I found my original design. When I call the original design, is really what we were intended to do, when it feels natural what you're doing. And I was lucky enough to have a mentor very early on in my surgical training that was a breast surgeon. I knew that I wanted to treat women. I knew that I wanted to create bonds with my patients. I just didn't know that this field existed. And thankfully, I found out about it very early on as a first-year resident. And once I was able to experience the spectrum of management of the breast disease and the relationships that you create with your patients, and how helpful and impactful you as a surgeon and as a physician could be through their journey, I fell in love with the field. And I realized that I was intended to do this, and that it was part of my original design. What I was intended to do all along. And so once I found that, my mentor allowed me to nourish my passion and my program. I was very verbal and vocal about it. So during my whole residency, I strived to be able to participate in their care, even when I wasn't on the rotation. And then obviously I ended up going to the University of Pennsylvania for my fellowship, where I really polished a lot of the knowledge that I had gotten from residency into becoming the breast surgeon that I am today. And so, yeah, I feel blessed because, a lot of people don't find that early on, or maybe sometimes they take longer, but I was lucky enough to be able to find it right away when I started my general surgery training.
That is great. Thank you so much for providing that background, that insight, and what makes you excited about your job and how we take care of patients here at MedStar Health and MedStar Georgetown University Hospital and MedStar Lafayette and really across the system. So let's talk about the specifics to breast health and breast cancer. Can you kind of get into a little bit about what some of our patients who end up needing a lumpectomy or a mastectomy, what does that typically look like in terms of your breast cancer and breast health journey? And can you talk about the differences between those two procedures?
So first and foremost, we have to talk about women getting screening mammography. And, I urge all of the audience here, if they have a mom, if they have a grandmother, if they have a sister, if themselves are in screening age, meaning if you're 40 or above, you should be getting a yearly screening mammography. Unless you have some indication to do it before that, that should be decided by your breast care specialist if you've seen one, or if you haven't, I urge you to do so. We recommend yearly mammograms for women who are at average risk of breast cancer. And obviously there is the idea also of doing self-breast exam. I would call it more self-breast awareness. You are with your body every day, and therefore you're the first person to acknowledge if there are any changes, anything that you are finding different, such a new lump, a new bump, skin changes, anything that is that you consider that is not really your normal kind of evaluation of yourself in your breast exam or your breast awareness. If you have a screening mammography and then you need additional imaging because they find something that's abnormal, and then you end up getting a biopsy or a diagnosis of breast cancer, that's when usually patients are referred to breast surgeons like myself. And once we meet the patient in the office, obviously we review the pathology, we review the radiology findings, and then we have a discussion with patients. As I mentioned to you, not everybody's a straightforward path to surgery right away. There are some patients that need preoperative systemic therapy, like chemotherapy. And then there are patients, yes, they do have surgery up front. And those are things that we as surgeons decide up front when we meet with the patient during their consultation. But now let's say that, the patient has, we've come to the point where the patient does require surgery up front, or they're requiring surgery at, after preoperative chemotherapy or systemic therapy. When I started residency, we used to say that there was a 4-centimeter tumor cutoff for mastectomy. So if anybody who had a larger tumor, we would offer mastectomy despite their breast size. And now, kind of years later, we've identified this thought that not everybody needs a mastectomy because there's no survival benefit. The only difference as far as their cancer goes is the risk of it coming back to the breast, which is considered local recurrence. So when I see patients and we have the discussion, if they have a really large breast and their tumor, we call it tumor to breast ratio, is it acceptable? Then we can do something that we offered at MedStar Georgetown University Hospital, which is called oncoplastic surgery, where the patient can preserve their breast by having a lumpectomy, which meaning just the removal of the breast mass or the breast cancer, and then having the plastic surgeon in the operating room at the same time to do a reduction and a lift. And it happens in both breasts. So patients wake up and they're symmetric. They've had their cancer removed, and they may be getting something that they wanted and that they haven't been able to get before, which is a reduction and a lift. And so I always, a lot of patients have, shown improved quality of life and satisfaction with this because they feel that they can preserve their breast. They have an option. They're not pushed into a mastectomy that they may not be ready to do so at the time of their consultation or the time of their diagnosis, and then have something that they've maybe wanted before because they've had back pain with large breasts, or they've always wanted to have a reduction or a lift after having, breastfed and your breast having. The other thing that we do talk about, obviously, if the patient requires a mastectomy, because it can happen, we have patients who don't have an alternative, meaning patients who have an inflammatory breast cancer. Those patients are not candidates for breast conservation, like a lumpectomy. We do excise skin, and we need to excise the whole breast. And then there are some patients, for example, that have invasion of the skin, invasion of the nipple. And these are patients that sometimes their cosmetic outcome is not optimal if we do breast conservation, even after having preoperative systemic therapy. And so we do recommend at times to have a mastectomy. And in these patients who are not inflammatory breast cancer, but patients who solely have a breast cancer that is not locally advanced, or patients who don't have skin involvement, then those patients are candidates for either a skin sparing mastectomy or a nipple sparing mastectomy. Obviously, nipple sparing mastectomy has been around in Europe since the 90s, and the United States was adopted in the mid 2000s. And I think now, the numbers are even more so. More breast surgeons are doing it because we have good literature to support the oncologic safety of this procedure, meaning the safety of the cancer population. And so we are able to offer it at MedStar Georgetown University Hospital, nipple sparing mastectomy for a lot of our patients, thankfully. And, when I went to medical school, which is in 2000, we used to extirpate the whole chest, the skin, the nipple, not the chest wall, but really just a lot of the skin. And the reconstruction outcomes were not as good as we are seeing them today. I mean, I have patients who we do mastectomies on, and they're like, Dr. De La Cruz, I feel like my body, I recognize myself in the mirror. I feel like I'm the woman that I was before I went into surgery. And this is great. I mean, for me, it's the most satisfying thing to hear, that I'm able to treat their cancer and have them still feel like themselves and recognize themselves in the mirror, taking a shower, when they're, checking themselves after, changing their bras and stuff like that. And so, we are very fortunate to have such, great surgeons, except myself, and obviously I'm including myself, but, we have a great team of surgeons, breast surgeons in our program, all along MedStar program, as well as our strong and amazing plastic surgery department, who provides the reconstruction for these patients, which is obviously, we can't, again, we go back to the team effort. This is not a one-woman show, one-man show. This is truly a team effort to make sure that our patients have the best outcome possible.
Right. Well, thank you so much. Can we go back to what you mentioned about the types of patients that would get a lumpectomy versus a mastectomy versus oncoplastics? So you mentioned mastectomy patients are typically not candidates of a mastectomy if they have inflammatory breast cancer. Is that correct? And can you talk a little bit more about what that is? Is that correct?
So pretty much anybody today. So we have, so this is a little bit kind of in the weeds, but I'm going to try to generalize it without really leading people down the false lane of who can and who can't. Again, this is generalized to each patient, right? So what somebody today may not be the same thing that I evaluate another patient tomorrow, because not everybody is very unique in their own journey. And so we have to be very careful on how to not generalize who is a candidate for lumpectomy. I feel like if a patient has a tumor to breast ratio that allows for me to remove the tumor without leaving them with a big dent, a big concavity, a deformity, then that is a patient who we recommend lumpectomy to. Who has a large breast, let's say, and their tumor is small, or their tumor is still large, but they have large breasts, where we can do a lumpectomy, meaning take out this tumor safely with margins. And the plastic surgeon can do a lift and a reduction, meaning, or just mostly a lift of the nipple, and then do the other side to match it. Then these are patients who qualify for oncoplastic. Usually the patients that qualify for oncoplastic surgery are patients who have larger breasts. The patients with a smaller, like A cup, small B cup, those patients don't have a lot of tissue to be manipulated and moved.
Right.
And patients that sometimes we can't offer them oncoplastic approach to their lumpectomy. And then obviously mastectomy, anybody can have a mastectomy if they want it. Now, what I was trying to say is that patients who have inflammatory breast cancer are really the patients that we do not recommend a lumpectomy, meaning breast conservation. And these are the patients that require from our guidelines to have a mastectomy, and they cannot have a nipple sparing mastectomy because we do have to remove skin, because inflammatory breast cancer is a cancer that is affecting the skin or the dermal lymphatic invasion, meaning the skin itself is invaded by cancer. And those are the patients that we cannot leave the nipple, we cannot leave a lot, so we have to remove areas of the skin, and we cannot simply just do a lumpectomy. Now, when patients decide to have a mastectomy, the mastectomy options that we offer the patients, again, are unique, are personalized. Again, it's fighting the cookie cutter decision-making of cancer care in the breast world. It's really truly about getting to be in a place where the surgeon who's seeing you is taking you as a unique individual going through your own journey, and therefore personalizing that surgical approach, the medical systemic approach, and the radiation approach to that single individual. And that's what we offer at MedStar Georgetown University Hospital. And truly, it's something that I promote, and I tell patients when they come to me that if they need to feel that their cancer treatment and their surgical options are really tailored to them, because not everybody fits in the same box, and that's a thoughtful with the patient and the surgeon, to make sure that they get offered the best option possible to not only oncologically, but also for their lifestyle and their needs.
That is great. Thank you so much for going back into that and explaining the types of options for the patient, understanding that it is unique to each patient and you would get a personalized experience because not everybody fits in the same mold. And it really is a conversation that you have with your team and probably your family as well, I would imagine. So thank you for that. Before we get into some more questions, I just wanted to take a moment and welcome our newer viewers. If anyone's just joined us, welcome. Thank you for joining us. We are here with Dr. De La Cruz, breast surgeon, talking about breast health and breast cancer in honor of Women's Health Week. If you haven't yet given us a like, please do so. Let us know you're watching. Share this with your family and friends. And we're still taking your questions, so please post those in the comments and we'll ask those to Dr. De La Cruz. We have talked so far about the importance of screenings. We have a health risk assessment that is being shared in the comments, so you can see if you are you qualify for a mammogram based off the guidelines that Dr. De La Cruz mentioned earlier. You can always watch the replay or take that assessment, and we encourage you to set up an appointment if you are in need of a mammogram. And we also talked about the different types of breast cancer treatment should your mammogram come back with some findings that would require you to go down that journey. So let's talk a little bit more about the breast treatment and some of I wanted to go back to the reconstruction side of things and then also talk about side effects. So Dr. De La Cruz, you talked about reconstruction when you have a lumpectomy with oncoplastics. Can you talk about the types of reconstruction that are available for patients who get a mastectomy? And can you talk about side effects for mastectomies?
So this is a great question. Obviously, I'm not a plastic surgeon, so my description of the reconstruction is going to be an overview of what the plastic surgery team does. And so when I counsel my patients about having a mastectomy, obviously we do talk about, so I'm going to go and start first of all with the side effects or the risks that we do have when patients have a mastectomy. So obviously it's considered a fairly low risk procedure as far as bleeding and infection. It's considered a clean procedure. So the risk of surgical site infection is about 3%. We do talk about chest wall numbness, which is something that a lot of people probably, there was actually a talk, a journal, not a journal, I'm sorry, a article in the New York Times several years ago that talked about how a lot of women underwent mastectomy without counseling about chest wall numbness post-mastectomy. And I remember that as I mentioned, I had a great mentor, and she used to always counsel patients about chest wall numbness, which happens in about, usually it's very objective. So there's no way of really quantifying how much numbness people feel. But, I always ask my patients after mastectomies, how much have they recovered from their sensation after surgery? And I would say, if I would give it a ballpark number, it's about 30% of women have loss of sensation in their chest wall. And what does that mean? So they don't feel hot, they don't feel cold. So if you put an ice pack, if you put a heating pad, patients will not feel in a lot of their breast area that sensation of the temperature change. And it has to do with the fact that when we do a mastectomy, we take out some of the nerves that are coming from the chest wall that are leading the temperature regulation in that skin. So I always counsel my patients after having a mastectomy to never again put ice or heating pad, mostly heating pad, because the ice will melt, but the heating pad, some of the heating pads don't have a timer. And I've had patients who fall asleep with a heating pad and they burn themselves. That I talk to patients actively when I'm consenting them for surgery about it. Now, there is something that we are now doing at MedStar Georgetown University Hospital, which is called the nipple-sparing mastectomy with nerve preservation. And this is essentially kind of the optimal, kind of something that I wanted to have. I'm glad that we're seeing in my lifetime as a surgeon, but I didn't see this when I started residency or when I, and now it's the nerve preservation. Nipple sparing mastectomy is where we preserve that as many possible innervation to the superficial skin layer. So that sensation of touch and that sometimes erogenous component to the nipple that is completely lost when we do non-nerve preserving nipple sparing mastectomy is somehow preserved. Now, is it preserved on everybody? Probably not, but we try to do it in a very thoughtful way when we operate on patients to allow them the best chance at recovery or preservation of that sensation, which is normally lost in non-nerve preserving nipple sparing mastectomy. Patients who have a skin sparing mastectomy, again, chest wall numbness is something that patients experience. And then there's obviously the other thing that we do talk about is post-mastectomy pain syndrome. And this is something that we do counsel for all patients, and it has to do again with nerve pain that happens from the regeneration of nerve or from the cutting of the nerves during your mastectomy. This happens in about 20% of patients. It doesn't happen right away. It usually happens 2 to 3 years after surgery, where patients will feel a sharp shooting pain. Some people call it phantom pain. A lot of people know about phantom pain from amputations. It's the same idea. We've removed a part of the body. The brain is still trying to assimilate that part is no longer there. The nerves are firing signals to the brain, telling it, where is it? It's not there. And that causes pain that is related to the pain from the nerves, not necessarily a pain as if I would hit you and you would get a bruise and then you can take Tylenol and it goes away. It's a little bit of a different type of pain. So I do counsel my patients. These are probably the most important things that I talk to patients about. There's there's other bigger list of things that, patients who, for example, can get seroma or fluid collection after a mastectomy. That is temporary and it goes away. Some patients develop edema or lymphedema of their breast. That's very uncommon, but it can happen. Again, it's accumulation of fluid in the skin from having lymph nodes removed in the lymph underneath the armpit when we do cancer surgery. Now, these are kind of things that we talk about for mastectomy patients as a breast surgeon when I counsel them for undergoing surgery. Now, the plastic surgery approach is obviously, it happens at the same time. When the patient wakes up, their reconstruction is done. And there are 3 things that we could potentially do. So there's actually 2 things. There is implant-based reconstruction that is either with a tissue expander. A tissue expander is essentially, I do the mastectomy. I remove 98% of the breast tissue. And then the plastic surgeon inserts in the area a balloon that you would call a balloon. And it's not inflated, meaning it's flat. And this allows for increase of size or expansion of that area, right? Or creation of, kind of getting to that point where you want to be, the size that you want to be over time, usually about between 2 to 3 months, where they fill it up with fluid every 2 to 3 weeks. And then once the patient is the size they want, or the tissue on top of it, the skin is fully healed, then they replace that with an actual implant. And this stage approach. In a lot of our patients, we do direct to implant, meaning I do the mastectomy and the plastic surgeon is able to put the implant right away. And this is obviously a decision that the plastic surgeon makes in the operating room based on several factors, such as how much blood flow the skin has at the end of my surgery, and how safe it is for them to put an implant in that is fully expanded, meaning the full size of your breast, reconstructed breast, because some impact the skin blood supply, which causes something that we call skin necrosis, meaning the death of the skin in that area. And I always tell patients, when you scrape your knee and you get a scab, that's, we've kind of de-epithelized, meaning remove the superficial skin layer. And that can happen sometimes from not having enough blood supply in the breast. So you'll get a scab. And sometimes you get new skin buildup, but sometimes you don't. And then the plastic surgeon has to take out that area and close the defect. So that's what we try to prevent when the plastic surgeon looks at the breast flap, meaning the skin, during surgery, done my mastectomy, and they make that decision using technology called the SPY technology that we have at MedStar Georgetown University Hospital for them to assess how much blood supply is coming to the skin, and then they make their decisions according to that. And obviously the other option is direct, it's your own tissue. So it's called autologous tissue reconstruction, which is, in layman's term and kind of what a lot of people understand it to be, it's a tummy tuck. So you get a tummy tuck and fat that is removed from your belly is placed in your breast for reconstruction purposes. This is a more labor intensive procedure. We do it at MedStar Georgetown University Hospital, in a weekly basis. Our plastic surgeons are world experts on this, and they are very proficient at doing them. So I would say that if you're going to have that type of reconstruction, you should go to a place that is done often, not someone who does it once a year, because this is obviously the success of this procedure is based on someone who does it, often, and that they feel very comfortable, because there is a lot of technicalities to it. So I recommend patients out there who are looking for this type of reconstruction to go to places that are specialized in doing this, with surgeons who are board certified, who have training, in this microsurgery, and that are proficient at doing it, because the complications from this procedure are not small if it's done in the unskilled, or not unskilled, but the people that don't do it as often, or patients, the surgeons who are not as proficient at doing it. Success rate is really impactful for our patient care. So I would say that the decision about what type of reconstruction the patient gets is based truly on the plastic surgeon, and they look at your body type, and how much they have in order to remove from your breast, from your abdomen to your breast, and what size you want. And those are things, again, personalized care. If I could, I think the whole conversation should be personalized care of breast and breast care in general, because and I sincerely believe that it impacts patient outcome when we are doing it thoughtfully and uniquely to the patient.
Absolutely. Thank you so much for that overview. We did also include some resources in the comments about our breast reconstruction team, and the information that you shared. Also, you mentioned lymphedema being a potential side effect of a mastectomy. We do have information about that as well. We have some great surgeons and folks from the plastic surgery team who are helping to not only treat lymphedema, but prevent it before a mastectomy. So that information is shared in the comments for all of our viewers.
And I was going to talk about that as well. So at our breast clinic, we've just implemented this machine called the SOZO machine, which is for early intervention of lymphedema. And we just acquired it, and we're going to be starting to roll out that testing in the next several weeks, which patients will come into our office with a cancer diagnosis and they'll be measured with this machine. It measures fluid shifts. So they'll be measured before surgery, after surgery, and all the visits after surgery for their cancer survivorship clinic and their follow-ups with us. And if there's any shift in their fluid composition, the machine alerts us that this is a patient that needs to be referred right away to physical therapy for prevention of lymphedema, as well as we will give them tools and educational material, as well as we'll prescribe them the sleeve before they develop lymphedema. And clinical trials have looked at patients who get this testing done, and it decreases the lymphedema, patients getting actual lymphedema from early intervention significantly. So we're excited to have this machine in our office, and I can't wait to be able to provide that services to our patients.
That's very exciting. Thank you so much for sharing that. As you were talking earlier about all the innovations that have happened in breast health and breast cancer treatment, and things that you didn't imagine that you would see in your lifetime, this is probably one of them, I would imagine, in addition to the things that you mentioned earlier about the nipple sparing, the nerve sparing. So are there anything else? What else do you think could be coming at some stage in the future? What's next for breast cancer treatment?
I think, Karen, we are doing a lot of de-escalation of the surgical management of breast cancer. And de-escalation means that we used to be very aggressive. We used to be very radical. And we have been more thoughtful at not being so, bold at surgically treating the patients. And I'm not saying not having surgery. I'm saying, yes, surgery is still part of the treatment, but doing surgery that is more thoughtful and that it takes into consideration the morbidity, meaning the complications and the risks of long life, debilitating side effects from our surgery. And how are we doing that, and what impact it has on the patient's quality of life? And ultimately knowing that, how does that impact their survival? And so I think a lot of the data, as I mentioned to you guys, breast conservation and mastectomy has the same survival benefit. Patients live the same. So that's something that we talk to patients about, because patients are like, I want to live longer. Well, yeah, the surgery are going to provide you with the same survival outcome. But one of the things that I'm really excited about, and I joke with my colleagues, because it's that in the future, potentially we won't be treating breast cancer. We'll be preventing breast cancer with treatments of like vaccines, immunotherapy drugs. And this excites me. As much as I love being a breast surgeon, I would love to not treat breast cancer. And I would love to not have women affected by breast cancer, and have women undergo all of this procedure and systemic therapy, and have women, I've lost someone very dear to my heart to breast cancer, 5 years ago, who I loved, and she was like my second mom. So I would say that I hope in the future, and in my children's future, for me to become an obsolete part of the breast world. And I love my job, and I told you it's my original design, so I don't know what I would do if I wasn't a breast surgeon. But I would say that it's what excites me the most, that there are so many clinical trials out there really pushing for this. And it's mostly because, we have 11, 1 of 8 women are affected by breast cancer. And that's a lot of women. And I speak to it because I am a woman, and I'm potentially at risk of having breast cancer. And I would love to know that one day we will be counseling young women about a vaccine to prevent breast cancer, like we have for the HPV gene and stuff like that, we can prevent stuff by, instead of having to treat it. And so if the future is very exciting. In the meantime, we do have a lot of exciting clinical trials available at MedStar Georgetown University Hospital. Our medical oncology group is amazing. They have a lot of open clinical trials, not only for patients who have early breast cancer like DCIS, but we do have also clinical trials looking at patients who need preoperative systemic therapy, looking at immunotherapy drugs that are impacting their survival, their outcome. And we also have a lot of clinical trials that are open for locally advanced disease patients or patients with metastatic disease. Having metastatic disease is no longer end of the road. We have a lot of systemic therapies that are out there. And I think there's a lot of clinical trials in the pipeline that are looking at treating these women and potentially making them either increase their survival, which we have made available already with systemic therapy, and but also making them something that we call no evidence of disease, NED, which by treating them, their cancer shrinks, their metastatic foci decrease, and they're on this treatment. And so these are clinical trials that are ongoing and that are very promising. And I think in the next 10 to 15 years, when I'm still young, I will be able to counsel patients. And again, as I said, be able to have so many more options. And again, this is where personalized care goes to hand in hand with this, because a lot of those clinical trials are going to be specific to tumor receptors, tumor genetics, and personalized tumor care. So it's not going to be, when I started residency, we used to give chemo to everybody. More than 1 centimeter, everybody got chemo. And now we're backing away and saying, wait, not everybody needs chemo. Maybe who needs benefits from chemo? Because again, chemo is not something that we would just want to be giving out. And it's not that it's, I say chemo is needed, and it does impact survival in the patients that need it and that benefit from it. And I think that now with all the genetic testing and genomic assays that we have available, we're able to be, again, more personalized, more thoughtful in who needs chemotherapy and systemic therapy. I mean, we also have more, we have genomic testing or just tumor testing for patients who have non-invasive breast cancer, like ductal carcinoma in situ, to make a decision about who needs radiation or not. And so now we're able to tell the patient, hey, your tumor, this is what it showed, and this is the benefit that your tumor will get if we give radiation. Or if, you may not need radiation for ductal carcinoma in situ based on this test specific. So again, these are all things that are so exciting in our field, that are really allowing us to expand this personalized approach to an even more personalized, more thoughtful, and not only surgical planning, but also the medical oncology world and the radiation oncology world.
That is very exciting. That makes me excited. I did not realize there were, you kind of hear things from friends and family that might be struggling with their breast cancer journey. I feel like it has even gotten, younger, I would say. There's more people that I know that are younger who are affected by breast cancer. So the fact that there has been so many innovations and options and the personalized care, all the things that you said, and it's not just, you think breast cancer, you think chemo, but that's not necessarily what it's going to be. It really depends on what your individual care plan is. So I think it makes the thought that breast cancer could happen to you or a family member or a friend a little less scary, maybe, because there's so many different options and survival rates have really improved. And even if you, and even I was going to ask, going back to just the prevention, I mean, the idea of having a vaccine would be just, I would love to see that in my lifetime. But what we're trying to do now is really the prevention side of things, having that self-awareness of changes in your body. But if you do see a change in your body, it doesn't necessarily mean breast cancer. Can you talk a little bit about that? If you get and there's something there, I feel like a lot of us just go straight to breast cancer, but it's not always the case.
It's not, and you're right. So again, going back to the self-breast awareness, and I mean it in a way not to scare patients it's really for you guys to be the first responders. And I call self-breast awareness the first responder. You are your first responder to your breast health. And it's not the fact that, like you said, most masses are not cancer, but you have to also understand that you're not working towards the majority of the cases that are benign. You're trying to avoid the minority of the time by being the early intervention person, the first. So I urge all women, if they feel something, to not disregard it. And not to say that it's always going to be breast cancer, but almost to kind of make sure that somebody evaluates it, and somebody is, that you're seeing your GYN, that you're seeing your primary care physician, and that they are maybe potentially ordering. If you've not had a mammogram and in your mammogram years, you're 40 and above, to get a mammogram. If you're younger, to see a provider so that they are able to say, okay, what is the best imaging for you to assess this new finding that you, as your first responder, has identified. It's like you said, it's most of the time is not breast cancer, but what if it is? Then you've actually made an impact on your own lifetime, to make sure that you've changed the course of your journey by being the first person to say, you know what, there's something wrong. I'm not going to disregard it. I'm not going to wait 3 months. I'm going to do it now. I'm going to make a phone call and make sure that I get in to see my GYN, that I go in and I see my primary care physician. And by the way, you were talking about younger. I mean, I've had women who are young in their 20s and that they say, oh, this lump is probably nothing, and they don't seek. Yeah. Now, is that the most common thing? No, but it can happen. So that's why I urge the young women, all women, but the young women, not to disregard it and say, oh, this is nothing. I heard in the news that it's probably a benign tumor. It probably is a benign tumor, but you don't know. And you don't know until you look and you find and you identify, okay, this is a benign tumor, then you can go on with your day and continue with your everyday lifetime. But if it is something, then you've impacted your life in a positive way by identifying this early or picking it up and being that first responder that we all need in our life. I'm with you 15, 20 minutes. I'm not with you at home. I'm not there examining your breast all the time. So if you do identify something, if I'm supposed to see you in 6 months and you feel something and you said, I just saw Lucy 3 months ago, I'm going to wait till 3 months to see her. No, come in and see me. Come in and see me, because things can change in 3 months, And so I always say that the news that was in the newspaper yesterday is not the news that is in the newspaper today. And things change, ever changing. So you make sure that you become that first advocate for yourself and say, you know what, I'm not going to let this go. I'm going to see a provider. And if it's nothing, it's great. But if it's something, I've acted upon it and I have no regret that I pushed this forward and that I've put it away and that I've delayed the care. Obviously, another barrier that we have is, kind of getting it out there to your friends. So if you have a friend who tells you that they have something, make sure to be the advocate for them and say, hey, you should have this evaluated. You should look up, or have your mom or your sister or your grandmother, ask them, when was the last time you had your mammogram? Have you had a mammogram? And kind of be a source of, if you feel that you are, getting your mammograms every year and that you're doing all the right things, then try to be the promoter of that in the women around you in your life. And also for men, men usually get diagnosed later and more locally advanced disease because they disregard breast masses. They're like, oh, this is nothing. There's nothing there. I don't have breast tissue. So I always tell women who have husbands or spouses or partners or friends or other men who have, if they feel anything in somebody's chest or they talking, that they recommend that they see someone. Men do get mammograms. Men do get breast ultrasounds. So it's not that they require for screening purposes, but if they have something abnormal, I'm letting you know that you can let them know that, yes, we do mammograms for men who have abnormalities in their breast exam. We do ultrasounds and we do MRIs. We do screening. We do imaging for patients who are male patients who have abnormalities in the chest wall and in their breast, and that they do have breast tissue in a lot of the cases. Not disregard that just simply because they are men. And so again, it's kind of getting in that mindset that to be the first responders. And I say, you're the first responder. You're there every day and you need to communicate with us what's going on so we can address any concerns. There are other that women should look for: nipple discharge that is spontaneous, that is bloody. Spontaneous means that you wake up and it's on your bra, on your shirt. You rub and you feel like there's something leaking, not something that you express. So if you express, most women will have some kind of leakage because we do have ducts that have lubrication in them, and we're made up of a lot of, most of us are, 60% of our body is made up of water. So like, yes, there's going to be lubrication in the ducts inside the milk ducts inside the breast. So if you squeeze your nipples, that's not considered pathologic. If it's spontaneous, it's considered abnormal. If it's bloody, meaning dark brown, red, these are things that you should also not disregard. And again, thickening of the skin that's new, abnormal, or rash that doesn't go away. These are things that you should look for, that you should, if you find it, you should look for a healthcare provider to assess you.
Thank you very much. That's really helpful to think about the benign side of breast health, breast cancer. And also I'm glad that you talked about men as well, because you mentioned earlier how breast cancer in men is an area that that really brought you and inspired you to be a breast surgeon, and something that you really focus on. So I did want to ask you about that. So I'm glad that you addressed that as well. And speaking of non-cancerous breast concerns, we did get a comment and a question from one of our viewers related to that. They had, you mentioned an ultrasound guided biopsy. This person, thank you, Bridget, for sharing and asking your questions. She had an ultrasound guided biopsy for a lesion on her right breast. It was not cancer, which she was happy about. But she did want to hear a little bit more about she said complex fibroepithelial lesions, or maybe you could talk just kind of about other things that could happen with your breast that aren't cancerous. And after a biopsy was done, she did have some pain. So can you talk a little bit about side effects of biopsies?
Okay. So first of all, I mean, there's such a broad spectrum of benign breast disease that we could be here for like 5 hours.
It's a whole nother Facebook Live.
We're not going to do that, but I would say that I would urge her, obviously, to see a breast surgeon. If she has not seen a breast surgeon, she should see a breast surgeon, mostly for follow-up. The fibroepithelial lesions, if this is what I think it is, the fibroepithelial lesions are considered benign, but in some spectrum, they could be, once we remove the lesion, they could be something called a phylloides tumor, which is a rare tumor of the breast, also considered benign. But it has sometimes they have a malignant potential. They're not breast cancer like the invasive ductal cancer that we have been talking about. They're a little bit more localized only to the breast, but they do need to be removed. Again, I can't speak for her specific case. I don't have all the details, and it would be inappropriate for me to be giving her medical advice. But the one thing that I urge her to do is to see a breast surgeon who will be able to guide her and see all her imaging and be able to give her a more personalized kind of like recommendation to her specific case. When we're looking at broad spectrum disease, obviously fibroadenoma is the most common breast tumor in about 70% of women. It does not have a risk of having becoming breast cancer, but it does have an indication for excision when they grow, when they're larger than 2 centimeters, or when they're causing symptoms. Along those lines, the other thing that is also quite common for women to have is ductectasia, meaning the dilation of their ducts, their milk ducts in their breast. Again, it's benign. You don't need surgery for that. And then there's obviously the cystic breast disease, right? So fibroadenomas and cysts are part of the fibrocystic breast disease spectrum. Most cysts don't need any intervention. Some of them need to be aspirated, meaning put a needle in and take out all the fluid, because they cause pain. They're stimulated during your period. So during your period or before your period, when your breasts get engorged, you may have some tenderness, and they may get bigger, and then they may get smaller afterwards. So these are all kind of things that we normally see. It's our bread and butter. We see them quite often. We follow patients for this sometimes we don't. It just depends if they recur, if they go away. Now, as far as the core needle biopsy, I get a lot of patients who have concerns about core needle biopsy because of spreading of cancer. There's no such, supporting evidence to say that it spreads cancer from you putting a little needle in and taking it out for sampling. We do recommend for patients who have an abnormality on their mammogram or ultrasound to first and foremost get a core needle biopsy. A core needle biopsy is done by the radiologist. They put a little numbing, they put a little needle in, they take a piece of tissue, and the pathologist looks at it and tells us the results. The reason to do this is mostly to be able to guide us in what we're going to do surgically, appropriate surgical management. If I was to go in there and just remove it, a lot of the times I don't have the preoperative information, and I may be taking out cancer that didn't need to come out first, that maybe they needed chemotherapy first, and I'm impacting their survival. And therefore, I'm always much of like, we have to follow guidelines and recommendations that are standard of care. And the core needle biopsy is the first step of any patient who has an abnormality on mammogram or ultrasound or MRI. Now, the side effects of that is obviously bleeding, infection. Obviously, they're putting a needle in, they're taking tissue out. So there's, they can cut through blood vessels. Again, it's considered a fairly low risk procedure. The pain that she's experiencing is from scarring from that tract. So they put a little needle in, and that tract scars and causes pain. I usually tell patients it can happen for up to a year. Sometimes patients have a lot of pain, not a lot of pain, but they get some sharp shooting pain, like the nerve pain I mentioned from mastectomy. They can get it from any surgical intervention in the breast, right? Because we're cutting through nerves, and nerves regenerate and they cause some sharp shooting pain. So it's not a constant pain. It should just be, maybe you're wearing a tight bra and then you release your bra and then you have a little sharp shooting pain. Kind of like when you're wearing like tight pants. I know when I gain a little bit of weight and my pants are tight, I take them off. I'm like, oh, that feels good.
Yeah.
But feel a little bit of pain and nerve, like kind of sharp shooting pain. And that's the same idea when your breasts are tight in your bra, or wearing a sports bra, or you run. These are things that kind of tend to stimulate that area of scarring and causes irritation. I would say that pain usually goes away, and it's just a matter of letting time heal. There's not Tylenol a lot of the time won't resolve it. The only thing that really works sometimes is ice, and make sure that if she's not wearing a bra at home, at night or when she gets home, to make sure she wears a supportive bra.
Okay, thank you so much. That was really great information for Bridget. Bridget, thank you for your question. I do have one more question before we wrap up. We're almost out of time, but we do have a question from Bonnie. She wanted to know about needle localization versus seed placement prior to surgery. I don't know much about that, but if you could talk about that a little bit and what's offered at MedStar Georgetown related to that.
Thankfully, that's a great question. Thankfully, at MedStar Georgetown University Hospital, we are a wireless lumpectomy and excisional biopsy institution. And I say thankfully is because the wire localization was created in the 1970s. And it's pretty much essentially what it is: a wire sticking out of your breast that is done by radiology the morning of the procedure to be able to guide the surgeon to remove the lesion. Now, this is not something that, it was done in the 1970s, and thankfully now in the 21st century, we've moved away from it in most institutions. And truly, for us as surgeons, first of all, patients don't have to go through this very rough procedure with a needle, potentially fainting or having, discomfort from having a wire sticking out of their breast until they're having surgery. So waiting with this thing outside, it's very unpleasant. The second thing is also, patients don't have the stressor of having to come in without eating, without drinking the day of surgery to have this procedure done, and being moved around the hospital to the radiology department to then come back to the pre-op area. And from our surgical standpoint, I do, and I hate to say, I don't say 100%, but I do about 99% of my procedures through something called hidden scar, meaning I do it around the area of the areola. So when the patient heals 6 months later, they barely can see the scar. The wireless lumpectomy or excisional biopsy, as she mentioned, which is the seed, there are many different devices that we use at MedStar Georgetown University. We don't use the radioactive seed. We use one that is just a metal seed called a mag seed, and it doesn't have radiation. It's fairly easy to be placed by the radiologist. It's able to be removed. There's no kind of downside to it, and it allows me to plan my surgical planning specifically so that I can hide the scar and I'm not impacted by where the needle is coming in from in the breast, which it used to limit me as a surgeon to where I could do my incision, because sometimes I had the needle coming in all the way over here and it was really hard for me to find it and remove it, get out from the skin, by doing it by a tiny little incision, which is what I like to do, through the areola. And now I don't have that limitation, right? And so patients come in any day before the procedure. They come in at their leisure when they're ready. They don't have to be in without eating. They can come in, have it done, be done with. And then the day of the procedure, they're focused on having their surgery. They come into the pre-op area. Nobody's shuffling them around from one department to the next. They literally have it and it's very streamlined. So yes, we do not offer, thankfully, wire localization at MedStar Georgetown University Hospital. And we only offer, but we offer the state-of-the-art, the newest technology, which is wireless lumpectomy or excisional biopsy. And I say and or because Excisional biopsy is done for patients who don't have cancer. So it's a excision of the lesion for patients who don't have cancer. It's called an excisional biopsy. A lumpectomy is only called for patients who have cancer diagnosis. So there's a big difference. So I have patients that come in and have a benign lesion removed, and I said I had a lumpectomy. Well, no, it was an excisional biopsy. But we use the same technology. We use the MagSeed, which is a wireless mechanism that we're able to identify it in the operating room using a metal detector. And it works great. Patients, love it. And again, they don't have to be with this wire sticking out of the breast, which is the way that I, 12 years ago, learned how to do lumpectomies and excisional biopsies. And I have not thankfully needed to do one probably in the last 6 years.
That is great. Another innovation in breast health and breast cancer treatment. So that is just wonderful. Thank you for the question, Bonnie, and thank you for giving that information, Dr. De La Cruz.
You're welcome.
Before we wrap up, I think, I heard a lot of, just to summarize everything that we talked about. Of course, the replay will be available for our viewers to rewatch the entire broadcast. But we did talk a lot about personalized care. We talked about the importance of screenings and being aware of your body. So maybe if we can close out just by reminding everyone about their screenings. There was a question from Kelly about who should get a screening and whether or not we recommend patients with relatives of breast cancer survivors to get their screenings and who that is. So Dr. De La Cruz, can you send us off with a reminder about screenings and anything else you'd like to make sure that our patients walk away with today after this broadcast?
So I'm going to say it again. All women over the age of 40 and above should have a screening mammography every year. If you have a family history of breast cancer, or you have a genetic mutation that has been diagnosed by genetic testing, you should see a breast surgeon to discuss when you should start screening imaging. So, but if you're out there and you don't have a family history and you don't have any relatives with breast cancer and you are 40 or above, you should call today and make a screening appointment at our MedStar Georgetown University Hospital Radiology Department. And I think that if you do have a family history, or if you have concerns about not knowing your family history and kind of wanting to be calculated your lifetime risk, or have had a genetic mutation diagnosed, you could see us as well at our program. We have a high-risk program that focuses on patients who are in this category, and we will be able to tailor, again, your screening imaging to your needs and to what you require to have. So, and thank you so much, Karen, for this opportunity. And let me know if you need anything else.
Thank you so much. This was a lot of wonderful information, a lot to unpack when it comes to breast health and breast cancer. So thank you for all the wonderful information. Thank you to our viewers for tuning in today and asking your questions. If you do have others, feel free to ask them in the comments, and we'll get those over to Dr. De La Cruz and get those answered for you. But if you'd like to learn more, make an appointment, we put some links in the comments to our health risk assessment, to some pages on our website to learn more. And you can also call 202-295-0560. Thank you again, and happy Women's Health Week, and take care of yourselves and each other.
Take care. Bye.
Bye-bye.